Welcome to HealthiHer, the podcast designed to inspire women to lead lives filled with health and happiness. I'm Dr. Amy Brenner, your host discussing nutrition, hormones, aesthetics, sexual health, and more. Join us each week as we dive into feeling better, looking better, and living better. Hey everyone, welcome back to another episode of HealthiHer. If you're about 40 years old or older and you've ever struggled with low libido, brain fog, fatigue, not sleeping, loss of muscle, body aches, you're going to want to tune into this episode because I have a really smart OBGYN on with me, and we are going to talk about all things testosterone, the myths, what it can help for, what some of the side effects are, what's the controversy behind it. So stay tuned to learn all about testosterone for women. So we have Dr. Nick Sherock. Welcome, Dr. Sherock.
Well, thank you, Amy, for having me. It's an absolute honor to be here with you.
So you and I have been friends for a long time because we have a very similar practice and practice traditional OBGYN for a long time. But can you give everybody a little bit of background about yourself and how you also became a hormone specialist?
Well, sure. I have been in practice since 1994 in Northeastern Ohio. I was with a large group for about 17 years before I went off on my own. Now I have uh, offices in Orville, Ohio, as well as Massillon, Ohio. Uh, when I went through residency, I was taught about hormones, and whenever I got done with residency and went into practice, I realized, this stuff works for some, but not for most. And it was probably about 3 years into practice when I went to my first course on bioidentical hormones.
3 years,
And
like out of residency, or 3 years when
three
you were in
years
your
out of
own practice?
residency.
Oh, really?
Yeah, yeah, three years when I mean the first 3 years of my practice that I went to a bioidentical hormone course, and it
In the
kind of
90s?
opened my
I didn't
in
even
the
know that was a
90s.
thing then.
It was, and it was very not very well known. And whenever I came back into practice, my associates weren't real keen on it. So I didn't do a whole lot of it. I didn't really advertise it, and then whenever I went out on my own, started utilizing it a lot more. And now it's become probably the largest part of my practice.
Because back in the 90s, now granted, I always think I was in college then or med school, but at least when I was in residency and first years of practice, like the only thing I remember really being available was Premarin and Prempro, which, if you've listened to this podcast, you've heard me talk about that. That's horse urine estrogen and a synthetic progestin. And that's pretty much what we gave everybody. And then when that kind of fell out of favor, then we started giving people like things like Activella and FemHRT, which, but that's what I thought was really only available. So it surprises me that compounded hormones or bioidentical hormones were even a thing back in the 90s or early 2000s.
Well, they've actually compounded hormones have been around for a long time. Matter of fact, pellets have been around for a long time. Pellets first came out as a compounded hormone treatment in 1938.
Yeah. So you talked about training. Maybe your training was a little bit different than mine, but I would say you would think as a patient that going to your OBGYN would be a hormone expert. But I would say, at least in my training and my first 11 years in private practice, like that's the last thing I would say I was a pill prescriber. I was not a hormone expert. Like I learned the basic chemistry and in the first 2 years of medical school, but we didn't practice basic physiology and medicine in private practice. Is we prescribed Premarin and Prempro, and if that didn't work, then here's some antidepressants and here's some sleeping pills, and then if that didn't work, like go to a psychiatrist. Like that's all I really had. So I did
You're
not get a lot of training in management of menopause and didn't really dive into that until I started my own practice and quite honestly started experiencing a lot of symptoms myself. What about your training?
so whenever you're a resident in a large hospital system, a lot of who you see are young pregnant girls. And we did a lot of obstetrics and a lot of gynecology as far as surgery goes. Um, but hormones were something that were talked about in our lectures, but not really able to be practiced just because of our patient population. And basically, most OBGYNs are taught that if a woman has a uterus, that you're supposed to prescribe her an estrogen plus progestin for her menopausal symptoms. And this is what I was taught in residency. And if she didn't have a uterus, that you just gave her estrogen. And like I said, when I actually went into practice and my patient population changed, and I was dealing with a lot more women that were perimenopausal or menopausal, I really had to step up my game as far as understanding hormones and as far as prescribing them better. There were times that women that were on estrogen by themselves that didn't have a uterus, they'd start developing symptoms of estrogen excess. And they didn't feel well then. It might have helped with the hot flashes and night sweats, but it didn't help with a lot of the other things. The I remember way back when I first went into practice that patients that I had that didn't do well on Prempro or Premer and Prevera, uh, that I'd oftentimes prescribe something called Estratest, which was a combination of an estrogen and a methyl testosterone, which is a synthetic testosterone that was given by mouth, and it helped a lot of those people, and it opened my eyes to understand that testosterone in women certainly seemed to help a lot of the symptoms that I couldn't manage with just estrogen and progestin by themselves. After a while, my Estratest was taken off the market, and then we were kind of left without any significant alternatives. And it wasn't too long after that I, like I said, started learning more about bioidentical hormones and started learning more about the importance of testosterone in women, which is grossly overlooked in our literature.
Sure. If you've listened to all of my hormone podcasts, you've probably heard me that the people interchanging progesterone with progestin is one of my pet peeves. And even a lot of OBGYNs, when I'm in different doctor Facebook communities or even reading the medical literature, I will read or see people like talking about and using the word progesterone. And then when you dig into it, they're actually a progestin. But um, I've explained it a million times, but if you haven't listened to it, could you explain to our listeners what the difference is between a progestin and and bioidentical progesterone?
Sure. So bioidentical progesterone or progesterone is what the body actually makes. And both women and men have progesterone in their systems, uh, but it is specific as far as the chemical structural nature of it. When you talk about progestins are really chemically modified progesterone. And there's a few reasons as far as why they're chemically modified. The pharmaceutical companies, in order to get a patent on a substance, they aren't able to patent anything that is naturally made in your body. So they will chemically modify it, and they do that for a couple of reasons. They do that so that they can, number one, get a patent, and number two, they might be able to use smaller doses of certain medications that can be more effective. But whenever you structurally change that hormone, you definitely change its action and the potential side effects for every individual. As you know, most birth control pills are progestin dominant, and every birth control pill seems to have a different progestin. And those progestins really make a big difference as far as how well tolerated one particular pill is compared to another birth control pill.
Yeah. I've called synthetic progestins like zombie hormones. Is they're kind of
Mhm.
sort of like bioidentical progesterone, but not exactly right. So kind of like a zombie. It's kind of like a human, but something's not right with it. Or I've given the analogy is it's kind of like maybe like Splenda and or those artificial sweeteners and sugar. Like if you baked a cake and it said add a cup of sugar, but you added a cup of Splenda, like they're kind of similar, but your cake's not going to come out right.
No,
Yeah.
you're absolutely right.
Yeah. All right. So let's get into testosterone. let's talk about, first of all, what are all the good things that testosterone does in a body, specifically for women?
Oh boy,
Or do women even need testosterone? First of all, I thought that's for men, some people
well,
say.
interestingly enough, testosterone in women, actually, women make more testosterone in their lifetime than they do estrogen. It really is a very important hormone for them, and it has a lot to do with a lot of things. It can help uh, with energy. It can help with lean muscle mass. It can help to um, improve your exercise tolerance and your recovery. It can help with keeping bones strong. It can help with cognitive ability. There's so many, and not to mention the libido issues associated with testosterone. And testosterone is an interesting thing because right around the age of 30, in both men and women, testosterone just gradually begins to decline every year. So that each year we get a little bit less, and a little bit less, and a little bit less. And I thoroughly believe that whenever it comes to hormones, that most of us have this tipping point. And when our levels are above that tipping point, we tend to feel pretty well. But as soon as they go below that tipping point, we don't feel so well.
Yeah.
And the problem with aging is that it never gets better.
Yeah.
It just
You
continues to
I'm
happen.
sure you hear this in your practice, like from some patients, is when they go through menopause and they start having hot flashes and they're like, I'm just gonna tough it out. I'm just gonna get through it. And what is your response when you hear that from women saying, like, I'm just gonna like get through menopause? Like,
Yeah. Yeah. I don't agree with that. I think more and more and more we're seeing information that talks about uh, the benefits outside of the hot flashes and night sweats that are really good for women's health. Matter of fact, the American Heart Association they're big proponents of women going on and remaining on hormone replacement therapy, just because it seems that women don't tend to develop heart disease until after they go through menopause. Now, there's certainly some exceptions to that. And we all know of people who have heart disease at young ages for various reasons. And I believe a lot of that is genetic. But as women go through menopause, their lipids start to change, and the way that their body processes things start to change, and they start to develop more and more plaques into their arteries, which eventually leads to more heart disease. There were a couple studies, pretty big studies, that came out right around the end of 2019 that really looked at this issue of hormone replacement therapy in postmenopausal women, and and both these studies showed that there was a 30 to 50% decrease in risk of all causes of death in women who were on hormone replacement therapy as opposed to those who weren't. Now, we never hear that in the news.
no, it's not
Uh,
newsworthy. It's not a catastrophe. It's not doom and gloom, which is, what the news is all about. So
Correct.
yeah.
Yeah. So whenever women tell me that they're just going to suffer through it, I very kindly explain to them. I said, you don't really have to live like that, and there's all kind of options and things that we can try and things that we can do, and we can certainly look into your hormones and make sure it's not something other than just going through menopause. Make sure there's no underlying thyroid disorder or adrenal disorder, or even significant vitamin deficiencies that can make a difference.
Um, I like that you talked about heart disease, and I would imagine your practice is similar to mine. Is the majority of patients come and are wanting hormone therapy because they have, this list of symptoms. But I- and that's why most people start. Occasionally, I'll have somebody who's really well informed and said, "Look, I just went through menopause, and I'm fully aware of the health benefits of hormones, and they want to start hormone replacement therapy." And you touched on that, if you start hormones, that it's going to reduce your risk of heart disease. But that's another reason why I give patients is, you can suffer through it, but you're actually doing yourself a disservice by not taking hormone replacement therapy. So, can you touch on some of the other health benefits of why somebody should consider hormone therapy, even not just as it relates to symptoms?
Sure. There are declines in libido. That happens to just about every woman as they seem to go through menopause. Matter of fact, it's really unusual when that doesn't happen. There are also problems like vaginal dryness, lack of energy, fatigue, mood swings, irritability. There are things like loss of muscle mass, and loss of muscle mass in life is huge. Uh, it's so important that as we get older that we remain strong. And that lean muscle mass in our bodies is really the main factor for metabolism. So as
And
we
that's
lose muscle mass,
testosterone. Estrogen and
right?
progesterone aren't going to contribute to that. That's strictly testosterone is
Correct.
for building muscle. So,
Correct. So as we lose muscle mass and our metabolism goes down, it also it worsens our insulin resistance. Hormone replacement therapy for women has there are so many things that it can improve. And you're right. I have people that come into the office and we give them a symptom list and ask them to look at that list and decide whether their symptoms are none. I mean, obviously none is none, but mild, moderate, or severe. And for so many of these people, they have moderate to severe symptoms that can easily be improved with hormone replacement therapy.
yeah.
Um, and I can't even begin to tell you how many of these people have actually gone to other practitioners, board certified OBGYNs, who were just told, oh, yeah, that's just something you have to live with. And
Yeah.
we don't feel that way in our practice. We really believe that that the whole idea of people coming to see us is to try to get all those symptoms to shift towards the none category, and we also use a thing called an MRS rating scale, a menopause rating scale that comes up with a numerical value, and the higher that value is, the worse people feel. And I tell them the whole idea is to try to get that number down to zero. And I thoroughly believe that we can do that because we've done that for a lot of people. And if we can't do that, I bet you we can get them pretty close. And it's really, really unusual. Matter of fact, I scratch my head and beat my head against the wall whenever it doesn't work for somebody. It's that effective.
Sure. So, in your practice, I'm sure you have, or let me back up and say, for some reason, the standard of care, I would say, if you would go to see 90+% of OBGYNs in America and you're menopausal, they're basically just going to talk about estrogen therapy. And, you and I could probably talk for hours of all of the benefits of estrogen and in menopause. That's not what we're here to talk about today. But can you comment, or how do you handle it in your practice if you have a patient who's just on estrogen? Maybe they've had a hysterectomy, or they're on or they're on a drug like Prempro, and they come to see you. How do you talk to them about considering adding testosterone?
So whenever they come in, and many of those people still have some issues, whether it's lack of libido or vaginal dryness or lack of energy. Estrogen and progestins tend to help some of the vasomotor symptoms like hot flashes and night sweats, but they don't tend to help all the rest of the stuff.
No.
And
Brain
and
fog, I
all
think, is a big one also.
huge, huge. And some women on estrogens may benefit with that, but not like testosterone. I talk to people. Actually, I listen to people and I just hear what they have to say. And I had one girl come in to see me that she was a banker and she had to deal with numbers all the time. And as she became perimenopausal and was going through menopause, she came in and saw me. She said, I'm surprised that this brain fog and forgetfulness is on your list of symptoms whenever you ask me about symptoms associated with menopause. And she said, the foggy thinking is just it makes it difficult for me to get through my day. And we talked about doing pellets, and she had heard about pellets from one of her friends. And so she wanted to go ahead and try pellets. And we went ahead and placed pellets for her and saw her back about 5 weeks later. And she said, all the hot flashes, night sweats, the loss of libido, all that stuff is gone. She says, but the thing that just amazes me the most is I'm just as sharp as I can be, and I'm back to the person that I was before experiencing all this.
Yeah. When I have patients come in and we'll say just on estrogen, which would be indicated if somebody's menopausal and had a hysterectomy. If not, they need estrogen plus, in my opinion, progesterone. I never give progestin long term.
I
But
agree.
when women come in and they're just on those, I'm like, it's fine. Like, I don't think it's wrong. And the data on estrogen in women is just expansive versus the downside of the published data that doctors like to read on testosterone is, not as big as estrogen. So it's
Correct.
fine. Um, and if you're okay with fine and it's controlling all your symptoms, but if you want great and optimal, then you might want to consider adding progesterone and or testosterone, because when you were younger your ovaries made all three. So just
Correct.
um and then I go through what we just went through of, well, here's what testosterone does in your body, here's how it can help. The other thing is I tell people, I saw a patient yesterday, is she went through menopause. Her doctor actually did blood work, which is unusual, because she had had a hysterectomy, and her
Right.
FSH, her brain hormone, her FSH was elevated, which goes up when you're menopausal, and her estrogen was basically undetectable. So they put her on an estrogen patch, like perfect. Like, I like it. It's fine. It's not great, but it's fine. But she's like, but then sit, and she goes, and it really helped with my hot flashes. Like, those are all gone. But now I just have achy all over. My whole body hurts. I have low libido. Um, I'm tired all the time. And one of the physiologic mechanisms that I explained to her is taking estrogen could actually make your testosterone even worse,
Right.
because it stimulates your body to make a protein called sex hormone binding globulin, and it binds up your testosterone and then makes your testosterone even worse. So that could be, I mean, could be, there's a million other things why she has all those symptoms, but it could be that that's the physiologic mechanism of taking estrogen without testosterone, actually makes your testosterone number or levels in your body actually go down. So
Yeah, you're absolutely right about that. And like I said, the testosterone really in our literature, testosterone on women has been grossly overlooked. And I really see that there's more and more and more studies that come out looking at the potential benefits of testosterone on women. And the trouble is, it's going to take time for people to understand that more and more. But you're absolutely right. The ovaries make estrogen, progesterone, and testosterone. And like I said, the women will make more testosterone in their lifetime than they will even come close to making estrogen or progesterone.
let's just go through the just kind of a highlight overview of some of the data of testosterone, because um, I would say this podcast is meant for patients, and but I do have a lot of physicians that listen to this, and maybe a physician who's critical of testosterone would say, well, I don't ever prescribe testosterone because there's no data. One time I was in an airport and somebody happened to look over what I was doing, and they're like, how could you do that? There's no data. And my quick answer in the airport was, well, I don't know what you're talking about. Like, there absolutely is data. You just haven't read it. Um,
Correct.
but can you just
Correct.
give a little high level overview of some of the data of testosterone in women? Like I said, and I explained to patients, it's nowhere near the data we have on estrogen, but there is data, published data on testosterone in women.
Oh yeah, there's a lot of it. If you do a PubMed search, you'd be amazed at the information that comes out on testosterone in women. Testosterone in women has been approved in the United Kingdom and Australia for over 80 years, and they have been and they have actually their similar counterparts to the FDA. They have medications there that have been approved for over 60 years. The data that is out there is really quite large. I mean, there's studies that look at the safety of testosterone pellets in women. There was a study that came out in 2021 that showed that the safety of testosterone women in pellets, they looked at 1.2 million pellet insertions in over 400,000 patients, and saw that the risks associated with it in the adverse events was less than 1%. That's really big information. There's also studies out there that look at breast cancer risks in patients on testosterone and show that those risks can be declined, or they can decline. There is also a decreased risk in recurrence rates in women with a history of breast cancer that do take testosterone. So, all these things, I agree with you. I thoroughly believe that there's a lot of information out there, but there's a lot of people who just refuse to look at it because it isn't what the mainstream medicine has touted.
Yeah. Even in the transgender community, which, we're getting a lot of data in that population of patients who are taking ultra high doses of testosterone. And,
Mhm.
Obviously the goal in that situation is to develop facial hair and get a more masculine appearance, but we're not seeing like medical problems in people that are taking mega doses of testosterone. We're, like you mentioned, we're seeing less breast cancer because mega doses of testosterone cause breast atrophy. We're not seeing like liver issues and more heart attacks and more stroke. Like, we're seeing what we expect with testosterone and the side effects that we are monitoring for in our female menopausal patients, so I
Yeah,
think
I
that
agree.
transgender community who's taking mega doses of testosterone for what they're trying to achieve has given us a lot of data of the safety of testosterone um, in women that are XX chromosomes.
Yeah, I agree with you. And whenever we treat women versus men, men do get about 10 times the amount of hormone that women do. So there is a difference in the way that we would treat someone who's transitioning to the way that we treat people who are just coming in for relief of symptoms like hot flashes, night sweats, loss of libido, vaginal dryness. And to be honest with you, testosterone pellets, it has amazed me as far as how effective that they are to treat a lot of those things.
Join us next week as we review methods of delivery, possible downsides of testosterone, and what official medical societies have to say about testosterone hormone therapy in women. Thanks for listening to HealthiHer. If you enjoyed today's episode, please leave us a quick 5-star review on your podcast platform. Your feedback means the world to us and helps others discover our show. Do you have questions or want to discuss a particular topic? You can reach us by emailing ask@dramybrenner.com or by calling 513-204-8403 and leaving a voicemail. We might feature your question or comment in an upcoming episode, so don't miss out on the chance to be a part of the conversation. And don't forget to subscribe so you don't miss any of our upcoming episodes. We appreciate your support and can't wait to have you back with us next time. Take care, and remember, your HealthiHer journey begins with you. This podcast is for general information only and does not constitute medical advice, the practice of medicine, nursing, or other healthcare services. No patient-physician relationship is formed. The information in the podcast and any references, material, or links are at the sole discretion of the listener and not meant to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not delay or disregard obtaining medical advice for any medical diagnosis or issues that they may have, and should seek medical care or advice from their healthcare provider for any such conditions.